Hi, so now I'm going to be talking about contraception and just giving you a basic intro to birth control. This is a very high yield topic throughout OB-GYN. You'll be seeing it both in L&D when you're doing postpartum birth control and in clinic when you're prescribing birth control options for women of all ages. So first I'll start off with why we should care. Basically, women need birth control. The average age of menarche is 13 years and the average age of menopause is 51 years old. The average number of years that a woman tries to get pregnant or is pregnant is about 3 years for having 2 children. So this leaves a woman with 35 years that she spends trying to not get pregnant. So then that means 35 years that a woman needs birth control. And we're not being very successful in our birth control counseling as it is. 99% of all women who've had sex have tried a form of birth control or contraception, but almost half of pregnancies are still unintended. And 46% of women with unintended pregnancies were using contraception at the time, either consistently or inconsistently, but either way, that's a failure on our part to prescribe and educate on birth control correctly. And it's important to recognize why patients may not be using birth control, and often it's a lack of education. So they might think that they could not get pregnant, so they didn't think that they needed birth control. They might not have minded getting pregnant, so they hadn't actively pursued it. It's always lovely when the partner did not want to use contraception, so this is often the age-old story of, oh, my boyfriend doesn't like condoms. It's like, okay, well, maybe true, but there's other options for you, so it's important to discuss further. Also, concerns about side effects of birth control and problems with access, which are both things that we can help resolve. So it's important to not make assumptions and offer contraceptive counseling to all women. So first, to start out this talk, I want to give a basic overview of female physiology. This is not super clinically relevant, but this will help you understand kind of where all the different birth controls are coming from and also the differences between them. And so I'll try to keep this as basic as possible, but it is important to just review. So we'll start with the development of the ovarian follicle, which releases the 2 main hormones that regulate the female menstrual cycle, estrogen and progesterone. So we start with theca interna cells, which have the enzyme desmolase, which takes cholesterol and turns it into androgens. So we can see the theca cells on the outside of the follicle here. Those are what are creating androgens. And then the granulosa cells, which are on the inside over here, are taking those androgens that the theca interna cells have created and converting it into estradiol via the enzyme aromatase. So what's stimulating all these? LH and FSH are the main pituitary hormones that will control the progesterone and estrogen production. LH will stimulate the theca interna cells, and then FSH will stimulate the granulosa cells. So that's all to produce estrogen. So where does the progesterone come from? So basically, once the ovarian follicle is released, as we can see here, the follicle releases and exits the ovary, then the empty follicle remains with the corpus luteum still intact. The corpus luteum, after the release of the oocyte, will secrete progesterone. And then after a while, if the egg is not fertilized, then the corpus luteum will regress and the cycle will start over. So this is just an overview of the feedback inhibition that goes on in the female reproductive physiology. So we have GnRH at the top, that's being secreted from the hypothalamus and stimulating LH and FSH secretion. And then, like I said before, LH will stimulate the theca cells and FSH will stimulate the granulosa cells. Now, feedback inhibition comes from estradiol, which will feed back onto both LH and GnRH. And then the granulosa cells are also secreting inhibin, which will feed back directly onto FSH. So now I'll just overview the menstrual cycle. So I kind of discussed this a little bit, but there are 3 stages. There's when you basically grow the lining, change the lining, and shed the lining. So first, to grow the lining, this is the follicular or proliferative phase, and this is primarily due to estrogen. So we'll see increasing amounts of estrogen during this first proliferative part of the menstrual cycle. Then we need to change the lining. So this is mainly dominated by progesterone. And while the follicular phase can be variable in length, the luteal phase, this changing the lining due to progesterone, this is always 14 days long. And at the end of this, if the woman is not pregnant, she will shed the lining because there will be a withdrawal of progesterone because the corpus luteum involudes, and then there will be no progesterone to maintain the endometrial lining, and the lining will shed. So in the middle of all this, there's ovulation. Basically, increasing estrogen will peak, causing positive feedback onto LH and FSH, which this surge in LH and FSH will cause the oocyte to be released from the ovary, resulting in ovulation. And after that, you'll see intense drop in estrogen, and then progesterone will take over. So when pregnancy occurs, the corpus luteum is maintained and progesterone continues to be secreted. Thus, the endometrial lining is maintained and estrogen and progesterone levels will remain high. They won't decrease like over here. Hormonal birth control tries to mimic pregnancy by maintaining relatively elevated levels of either estrogen or progesterone or both in order to negatively feed back onto FSH and LH and prevent ovulation or prevent endometrial lining changes of some sort, which we'll discuss further. So this is an overview of the different forms of birth control and their effectiveness. So basically we start at the top over here. We have the implant and the IUDs, and these are our best options for reversible birth control. We also have non-reversible methods, which is like the vasectomy and bilateral tubal ligation. But like I said, these are non-reversible, and so those are for when women and men are done with their childbearing years for sure. So other options we can go down into, which require a little bit more participation on the patient's side, is the injectable birth control, the pill, the patch, the ring. And then we can go down and basically we have decreasing frequency as we get to diaphragms, condoms, and withdrawal and sponge and calendar method and all those. And these are almost so ineffective that I don't even want to discuss them. But the condoms are important to mention because they're not very good at preventing pregnancy, but they're very good at preventing STDs. So if a woman is having sex with multiple partners or she's unsure of her partner's monogamy, even if we give her a better birth control for pregnancy prevention, we need to make sure that she's also receiving birth control and condoms for STD prevention. First, we'll talk about LARCs, which are long-acting reversible contraceptives. LARCs are our best form of reversible birth control, and this is because they can be placed in a woman's body for a number of years and require no participation on her behalf or her partner's behalf at the time of sex. And then also there's no like having to take a pill every day or having to change a patch every week, anything like that. It's all just done once every few years, and it's very effective. And so these are convenient, they're long lasting, they have a very fast return to fertility. Basically, once you take them out, the woman can get pregnant that day for some of these methods. And there's very low prescribing precautions because they have low amounts of hormone, if any hormone at all. And so the three different kinds that we have are the copper IUD, which is Paragard, and that lasts the longest. It's generally replaced every 10 years, but can last up to 12 years. We have the progesterone IUDs, which are Mirena and Skyla, and we have progesterone implant, which used to be the Implanon and now is the Nexplanon. So first we'll talk about the Paragard. The Paragard is the copper IUD. It's hormone-free, but it's also still very effective. Basically, copper is spermicidal. It inhibits sperm motility and inhibits acrosomal enzymes, so the sperm can't actually fertilize the egg. And advantages to copper IUD, it's a LARC, and there's few prescribing precautions just because it is hormone-free, so there's very few ways for it to cause damage or harm to the body. Disadvantages, basically the one thing you have to think about with Paragard is that it increases menstrual bleeding. This can either prolong a period or make periods very heavy. So this is not good for someone who already has like bleeding problems or has heavy periods already or has anemia of some sort. But otherwise, it's a very effective method. It's also important to note that with any of the LARCs, they do not provide protection against sexually transmitted diseases. Prescribing precautions, you don't want to prescribe it in someone with severe anemia, like I mentioned. You don't want to prescribe it to someone who has uterine structural abnormalities, like bicornuate uterus, didelphic uterus, something like that, where the integrity of the uterus might disrupt the Paragard's effectiveness. And also Wilson's disease, which is randomly thrown in there. That's the copper storage disease, and so it just causes a buildup of copper in the body, so don't want to add more copper to the body. The next IUD is the Mirena/the Skyla. I'll mention the Skyla, but at the Family Health Clinic at Santa Ana, which is the Irvine OB clinic, we don't actually prescribe Skyla right now, but we may in the future, and it's important to know about. These are the progesterone IUDs. They are progestin only, and the hormone level is very low, and it's almost entirely contained in the uterus. It thickens cervical mucus, it slows tubal motility, and also alters the endometrium to be unfavorable for implantation. Advantages, it's a LARC, so it's very effective. And also with Mirena, it's kind of the opposite deal from the Paragard. It causes lighter periods. It will cause some spotting in between periods for many women, but most women will have either drastically decreased periods or even no periods at all by 1 year of use. And it can be protective against endometrial hyperplasia and carcinoma because of this, because it will keep shedding the lining and preventing lining overgrowth. Disadvantages include spotting and bleeding between periods, like I mentioned, but this will go away usually after 6 months, and it doesn't protect against STDs. The difference between Mirena and Skyla, Mirena is slightly larger in size, has slightly higher hormone dosage, so the hormone can potentially seep into the bloodstream, but it's still low dose, and it's formulated for 5 years of use. Whereas the Skyla, it's slightly smaller. It was designed for nulliparous women who sometimes expelled or couldn't fit the Mirena IUD. It's slightly less hormone, and so it's even more just contained to the uterus. And so women who have had some of the hormonal side effects with Mirena prefer Skyla for that reason. But otherwise, they're pretty much the same effectiveness. Skyla is just formulated for only 3 years. So the next and last LARC is the Nexplanon, which is the progesterone implant. It goes inside the woman's arm, and it releases low-dose progesterone hormone into the woman's bloodstream. It suppresses ovulation by inhibiting LH and FSH, and it also does the other effects of progesterone like the Mirena and Skyla, thickening cervical mucus, slowing tubal motility, and endometrial atrophy. Basically, to place the Mirena, you have to place it every 3 years into the arm subdermally. And advantages is it's a LARC, it can decrease menstrual cramps and pain. It can also cause a decrease or lighter periods, just not as drastically as the Mirena. And then another thing to know is that some progesterone contraceptions can affect bone mineral density, but this one does not. It's very low hormonal effect, so it doesn't have that problem. And it's also safe to use in women with uterine structural abnormalities where they couldn't use an IUD because of the structural integrity of the uterus had changed. So this is just how to implant the Nexplanon. And so you can see it's just inserted into the arm and then it's removed just with a scalpel, so it is an in-office procedure like the IUD placement. And also some disadvantages: they can have irregular menses, but they're usually lighter, and doesn't provide any protection against STDs. And the most common hormonal side effects, because this is a hormone that's released into the bloodstream, is headache. They can have some weight gain, acne, breast tenderness, and emotional lability. But this is similar to hormonal effects seen in the hormonal contraceptives, which we'll talk about next. So combined hormonal contraceptives. So these are the pill, the patch, and the ring. And normally when deciding between these different options, I basically ask a woman what they can tolerate in terms of how much participation they want to have. Can they remember to take a pill every day? Some women can, and some women will actively say absolutely not. And so then we go, okay, how about a patch every week? Can you replace a patch every week? If that's not tolerable, then can you replace a ring every month? And if they can tolerate that and they don't mind a ring in their vagina, which they cannot feel during intercourse, then that's a great option because it's only once a month. Basically, the primary function of these hormonal contraceptives is they have estrogen and they have progesterone. That's the combined part. So the estrogen inhibits ovulation. So it inhibits the LH surge, inhibits FSH, because if you can remember, it's that surge in estrogen midway through the cycle that will positively feed back on LH and FSH and release the oocyte. So if you have this constant steady stream of estrogen instead, then you won't get that surge, you won't get that positive feedback, and you'll inhibit ovulation. Then they also have the progesterone-mediated effects, like we talked about with Nexplanon and the Mirena, that they'll thin the endometrial lining, thicken the cervical mucus, and also impair tubal motility. So some discussion of advantages versus disadvantages. Advantages: there are some conditions where these combined hormonal contraceptives are actually preferred to the LARCs because the estrogen is really important for maintaining regularity of the menstrual cycle. And so for women with disrupted cycles, with dysmenorrhea, amenorrhea, oligomenorrhea, and any of these things that have disrupted the ovulatory cycle, this is the preferred treatment. This includes PMDD, polycystic ovarian syndrome, where they have their period very irregularly once every few months. And it can also be used in the treatment of hyperandrogenism, where they have acne or hirsutism. It can decrease these effects. It also can reduce abnormal uterine bleeding due to fibroids, as well as pelvic pain due to endometriosis. So these are certain conditions where you might actually think of a pill instead of the IUDs. It can also decrease the risk for certain cancers. So ovarian cancer especially occurs because of disruption, continual disruption in the ovary leads to having to repair the ovarian stroma, and then this can lead to mutation accumulation as they keep repairing. Basically, through inhibiting ovulation, then these combined hormonal contraceptives will prevent this disruption, prevent this need for constant repair, and be protective against ovarian cancer. So that's a really important one to maintain. If a woman has a family history of ovarian cancer, this might be a good contraceptive option for her. Disadvantages: there are a lot of disadvantages to these birth control methods. They don't protect against STDs, and they are harder to achieve the perfect use versus a LARC, which requires very little user participation. Women will have to remember to use these for a very long time, and it's very easy to miss. There's also the risk of increased cardiovascular problems. It can increase hypertension, it can increase the risk of thromboembolus, and it can increase the risk of stroke. The one thing that is kind of an urban legend out there is that these combined hormonal contraceptions cause weight gain, but contrary to popular belief, that is not true. So just to talk about the differences and why you might choose some methods over others, the patch offers lower peak dose, so it has a little bit lower of that initial hormonal side effects, but it can also not be used in patients who are obese and weigh more than 200 pounds, just because the thickness of the skin becomes hard and it makes the patch unreliable method. And then the NuvaRing is placed in the vagina, so it's a little bit higher dose of hormones in the vagina rather than in the bloodstream. And one thing to note is it doesn't need to be removed during intercourse, but some people prefer it, and it can actually be removed and replaced for up to 3 hours. Advantages to the NuvaRing: it's a little more private than the patch, you can't see it from the outside, and it uses slightly lower concentrations of the estrogen. And then these are active contraindications towards combined hormonal contraceptives. Basically, you can kind of see a theme that it's cardiovascular problems, but smoking is a huge contraindication, diabetes for more than 20 years or with end organ damage, hypertension with a blood pressure greater than 160/100. These birth control pills and other methods have been shown to increase hypertension a little bit. and then a history of venous thromboembolism or stroke, history of ischemic heart disease or valvular heart disease, a history of lupus, and then a history of migraine, especially with aura. That's an important one to distinguish. This could increase their stroke risk if they are placed on a combined hormonal contraceptive. Also, history of breast or gynecologic cancer. So if they have a history, especially endometrial cancer or breast cancer, which are like estrogen receptor or progesterone receptor positive, then you'll be feeding any leftover cancer, you can be feeding them these hormones. And then a history of liver disease, because this can affect metabolism. So the next big birth control option that we have is Depo-Provera, and that is the injectable that is given once every 3 months, and it's progesterone only. So this is a much higher dose of progesterone, though, than the Nexplanon will be. And it's given into the deltoid or the gluteus maximus. It contains 150 milligrams, and it's given every 3 months. Advantages is that it will reduce menstruation, anemia. It can cause amenorrhea in some women, especially after continued use for more than 5 years. 80% will have amenorrhea. It can decrease menstrual cramps, and it can improve symptoms associated with endometriosis. It also decreases the risk of endometrial cancer because you're giving a lot of progesterone. And if you remember, endometrial cancer is often caused by unopposed estrogen, so high doses of estrogen without progesterone to shed the lining. So this is kind of counteracting that by giving high doses of progesterone. It's also very private. There's no sign that a woman has received this. It's just a shot that's given. So for women who either are teenagers and don't want people to know that they are taking a birth control or have to hide that they're taking a birth control method, or for women who are, maybe victims of domestic violence or something like that, there's someone who's trying to interfere with their birth control, this is a more private method they can use. It can also be used by nursing mothers, so you'll see this a lot on postpartum rounds where it's offered to women before they leave the hospital after delivering their baby. They can have an injection of Depo-Provera, and then at their 6-week postpartum visit, they can then decide on a longer-term solution if they don't like the Depo. There are a lot of disadvantages specific to Depo-Provera, though, so I'll go through the main ones. One is weight gain, so this is one of the few birth control methods that can cause and has been known to cause weight gain. The other thing is that it has a slow return to fertility because it is a shot. Basically, once you give it, you can't reverse it. It'll go away after a while, but that's 3 months that they cannot get pregnant. It's also known to worsen existing depression, so that's something that's important to screen for. And then it has a black box warning for decreasing bone mineral density, and this does not mean that you shouldn't prescribe it, and ACOG has said that you should prescribe it anyway, but it's just something to monitor, especially if a woman has known osteoporosis or something like that going on. It can decrease their bone mineral density. It will also cause irregular periods for the first 6 months that you give it. Just to touch on emergency contraceptives, this is one where actually not a lot of people know what's the most effective emergency contraceptive, but it's actually Paragard. So Paragard is 99% effective, and it can work up to 5 days after unprotected sex. This is because not only does it interfere with the sperm and the fertilization, it also interferes with implantation by affecting the endometrial lining. So it can work a little bit longer than the other options we have. The other options we have is Ulipristal, which is Ella. That's a newer one that more pharmacies are starting to carry. It's 85% effective, and it also works up to 5 days after unprotected sex. The next one that we have is the one that's most commonly known. This is Plan B. Plan B is also 85% effective, but it only works up to 3 days after unprotected sex. So sometimes Ella is preferred just because it can be used a little farther out if a woman doesn't realize it or something interferes with their access. And then you can also give combined oral contraceptives. They may work, but this is not the preferred method to give. So just an overview of kind of when we would give certain birth control methods over others in the treatment of certain conditions. So women with menstrual cycle difficulties, like I said, should be taking combined oral contraceptives like PCOS, anovulatory disorders, PMS, PMDD. That can be helped by combined oral contraceptives. And then fibroids are unique because fibroids can be prevented by taking combined oral contraceptives. In women who may have a history of fibroids that have regressed or have been removed by a myomectomy, then you might give them combined hormonal contraceptives to prevent new fibroids from developing. But if they have existing fibroids that are causing bleeding, you can give Mirena to decrease this bleeding. Other things that you would give Mirena for, like I mentioned, endometrial hyperplasia. This is another thing where you'll want to keep the lining as low as possible, and so you'll give something that sheds the lining, so progesterone, especially Mirena. If the woman has ovarian cysts or increased ovarian cancer risk, this is another reason why we give combined hormonal contraceptives. And just to note, what happens if a woman becomes pregnant and she is still using her birth control because she didn't know she was pregnant? So it's important to know what birth control method she was using. So if she was using an IUD, IUDs don't increase your risk of ectopic pregnancy, contrary to popular belief. But if you get pregnant on an IUD, there's a much higher chance that it will be an ectopic pregnancy. So it's very important to do a thorough check to see where that pregnancy is. Now, if they're taking systemic hormonal contraceptives, these hormones are just trying to mimic pregnancy, but in much lower doses than the body actually produces during pregnancy. So it won't interfere with the pregnancy, and it won't cause pregnancy termination or anything like that once the pregnancy occurs. The pregnancy will just take over hormonal control and cause much higher hormones than the birth control is causing. So that's basically an overview of birth control and the different birth control methods you will be talking to your patients about. The most important thing in contraceptive counseling is listening to a woman's options and educating them, because there's a lot of, my mom told me this, my aunt tried this and it didn't work for her. It's a lot of education they've gotten in the community, and that might not always be accurate. So you need to just take the time, listen to reasons why they might not want a certain birth control method, and then offer your knowledge of the side effects and what actually occurs, and then you can normally find a very good effective method for each woman if you just take that time to educate. So once again, good luck on your OB-GYN rotation.